Good evening to everyone joining us tonight. We are excited for you to be joining our GeneSight Engage webinar. We're just going to give some people a few more minutes to join before we get started, but thanks so much for joining. Hey, if you're just now joining us, we are just waiting for a few more people to trickle in before we get started. I am going to go ahead and launch a poll question for all of our attendees who are currently on. If you would like to answer, I'll go ahead and launch that now, and then we'll get started in just a moment. Okay, thank you to everyone who has engaged in this poll. I'm going to leave it open just for a few more seconds if you want to get your vote in or your answer into the poll question. And we're going to go ahead and get started. So hello and welcome to another GeneSight Engage webinar designed to explore how GeneSight can be used to inform medication selection for patients 65 plus. My name is Dr. Morgan Freese, and I'm going to be your moderator this evening. Please direct any questions that you have into our Q&A, so not the chat, but the Q&A, and we will answer what we can during this webinar, and we will be following up with a recording. If you have any questions after the webinar, please feel free to reach out to our team at GeneSightEngage@genesight.com. And now in our previous webinars, we discussed how currently available pharmacogenomic tests on the market can differ from one another and how these differences can significantly impact results and clinical outcomes. We've also reviewed the approach used by the GeneSight test to predict medication outcomes and examine the overall body of evidence supporting psychiatric pharmacogenomics. We also heard from a panel of clinicians regarding how those differences led to their consistent use of the GeneSight test in clinical practice. So in this session today, we're going to be exploring how the GeneSight test empowers clinicians to make more informed treatment decisions for patients age 65 and older by uncovering pharmacogenomic insights and how they can help reduce trial and error prescribing and support improved outcomes in this vulnerable population. So some of the topics that we're going to be discussing tonight include how the medication selection process for depression treatment in 65 plus. We're going to be talking about a case study that actually demonstrates how the GeneSight test helped to inform treatment. And then finally, the case for GeneSight, when it's used and how it's used in the 65 plus population. So with that, I'm going to go ahead and end the poll. And here with us tonight, we have three speakers with Myriad Genetics. So first we have Dr. Justin Wyrick. And Dr. Bryrick is a primary care physician who earned his Doctor of Osteopathic Medicine degree at West Virginia Medical School and completed residency training in Fort Wayne, Indiana. As an osteopathic physician, he focuses on treating the whole patient using mind, body, and spirit as an important pillar of health. And this is where his growing passion for pharmacogenomics fits in, allowing him to treat each patient on a more personalized level, which he truly believes is the future of medicine. We are very glad to have you, Dr. Lyra.
Thank you very much.
Yes. Our next panelist is going to be Dr. Whitney Brown. She is a dual board certified nurse practitioner in family practice and psychiatric mental health. Dr. Brown is a three-time graduate of Troy University, where she earned her Bachelor of Science in Nursing, a Master of Science in Nursing, and her family nurse practitioner track, and also her Doctor of Nurse Practitioner. She earned her postdoctorate certificate in psychiatric mental health at the University of Alabama, and she is the author of many peer-reviewed publications and the co-author of Sigma Theta Tau International Publication. Her research focuses on health promotion and wellness in underserved populations through technology. So it's also great to see you, Dr. Brown. Thank you for joining.
Hi, Karen. Thank you for having me.
And then our last panelist this evening is Dr. Hildy, and he is a pharmacy leader in the field of pharmacogenomics and precision medicine with a strong passion for patient care. He obtained his doctorate of pharmacy at the University of Arizona and has been practicing in Arizona since 2018. He currently oversees the integration of clinical pharmacists, pharmacist residents, and pharmacy technicians into internal medicine clinics across Arizona and New Mexico. Dr. Hildy has significant background treating treatment-resistant psychiatric illnesses. He understands the value of collaborative care in medicine and realizes it truly takes a village to improve health outcomes. He is currently an adjunct professor and preceptor for the University of Arizona College of Pharmacy, and he has a strong desire to educate both clinicians and patients on evidence-based medicine to improve the health of his community. So thank you so much for joining us as well, Dr. Hildy.
Thank you for having me.
Okay, so with that, I would like to start our conversation this evening just by asking each panelist, when and why did you start using pharmacogenomic testing in your practice? And Dr. Wyrick, we'll go ahead and start with you.
Yeah, patient walked into my office asking for specifically GeneSight. And at that point, I'd been very familiar with some of the pharmacogenomics ideas out there, but hadn't had any clinical experience with using any tests. And so she kind of got the ball rolling for me, and she was a success story right out of the gate. And so it kind of spoke for itself. And so throughout that time, I actually got experience with a couple other the genetic tests out there, and time again, I found it just fit better into my practice using GeneSight. I thought the results were a lot better. And so, I haven't looked back since.
Okay, love it. Dr. Hildy?
When I was in pharmacy school, we pharmacogenomics was just kind of becoming a thing. We had a class for pharmacogenomics, and then I really didn't utilize it much after that, short of clopidogrel testing. But then when the pandemic hit, we were overflown with patients who had anxiety and depression, and they were having difficulty getting in with the psychiatrists in our community. And so our primary care offices were basically forced to manage these patients, which we would normally refer. And we were seeing many of them virtually. And it just was another tool in the toolbox that allowed us to take better care of our patients and potentially get that treatment remission sooner.
Wonderful, thank you. And then Dr. Brown?
Yes, so when I actually first became familiar with GeneSight was actually as a student, and my preceptor was utilizing GeneSight, but it offered so much for the patients to be able to determine what was going on. And oftentimes you hear so many patients report that they have tried medications time and time again, and they're not finding the right fit for them. And GeneSight offers an explanation for that. And so telling my patients about this actually helps me build a rapport.
Love it. Well, thank you so much for providing that background. So for my first question, I want to ask, what percentage of your patient population that you treat for depression would you say is 65 plus? And Dr. Brown, I'll start with you since you just answered.
Sure. I would say roughly 25 to 30% of my patient population is 65 plus. It can vary, but those are the patients that I think truly benefit from it the most.
Gotcha. And Dr. Hildy?
I work for a very large internal medicine clinic kind of throughout multiple states. And so we have many different patient populations, but my primary practice here in Tucson, Arizona, our average patient age is 74. 80% of our patients are above 65 years old. So the vast majority of my patients are above 65.
Okay, wow. Okay, how about you, Dr. Wyrick?
Yeah, I'm about in the 35 to 40% realm with 65 plus, a lot of Medicare.
Okay, so it sounds like everyone has quite a lot of experience with treating this population. And we know that depression among older adults is also linked with longer length of illness. We know that there's often more depressive episodes and a greater risk of comorbidities. So next, I want to ask each panelist, how have you seen depression present in your older patients? And is it different than, say, how it might present in a younger patient? Dr. Hildy, let's start with you.
Yeah, I think that generationally people tend to present very different. So that's number one. Our older patients tend to, especially older men, tend to be more remiss to talk about their feelings to begin with and to seek help, unfortunately. On top of that, I think that older patients tend to show more physical symptoms because of that. And so patients may have increased levels of things like chronic pain or increased issues with cognition. And we may be seeing that just because of their depressive symptoms more so than in a younger patient.
That makes sense. How about you, Dr. Wyrick?
Yeah, I see a lot more depressive symptoms related to some of their social situations. And so a lot of them do not bring up depression, do not bring up anxiety. A lot of that is stemmed off of typical screenings, which I know we'll talk about here in a little bit. And so you need to be a little bit more pointed when you're talking to that population about some of the actual depression and anxiety that they're experiencing. But what I mean by social is you start to hear stories about them not spending as much time with family or them not spending enough time with friends like they typically do. And you start to ask why, and they like to blame it on a lot of physical symptoms. But a lot of it has more to do with the fact that they are, again, losing that mental fortitude, and they are kind of withdrawing, and that kind of accelerates, I would say, some of their mood symptoms.
Gotcha. Okay, how about you, Dr. Brown? How about your patient population?
Yes, I would agree with that. I think a lot of times in this particular population, people are losing family members. They are isolating for that fear of feeling like a burden to other people. And then also with the concept of the population and the way that they see depression. So depression may not look the way that they think it should look based upon social norms or other concepts. But yes, I definitely think it can look different. And you may see several patients who are geriatric are amongst you and you don't know it, but asking them could be the key as opposed to just assuming that they have the voice to do that.
Yeah, and I think
really
Casey said it well when he talked generationally. You know, each generation will kind of represent depression a little differently. Those core symptoms are all, you know, still standard, but how they present it are very different among the generations.
Okay, so that's really interesting. So Dr. Wyrick, what are some best practices that would be helpful to address the needs of this population when it comes to depression treatment?
Yeah, I mean, I think first and foremost, how you screen for it. There's a lot of different screening tools out there that are tried and true. You know, our organization, our practice has adopted PHQ-9s. We don't even screen with PHQ-2s anymore. We go straight to PHQ-9s. And then we have, you know, systems in place that, you know, Medicare set standards for getting these annual wellness visits in. And any other primary care provider out there knows very well what I'm talking about with these Medicare annual wellness visits and how important they are, not just for reimbursement, but again, for quality in general. But as a part of that tool, we use the PHQ-9, and that oftentimes opens the door for some of these conversations. And so that definitely fits into best practice. But when it comes to best practice too, with treating their mental health, we use that combination approach. We are focused a lot on, yes, psychotherapy, as well as pharmacotherapies, as well as blended social and physical interventions too, because we know that mental health is not just a mental illness. It is a culmination of both physical, social, spiritual, as well as their mental health. So you gotta incorporate all those and meet patients where they're at, especially in that 65-year-old population, as we talked about, socially withdrawing and not having some of the support or some of the freedoms to manage their own medicines or to manage some of their other IADLs and things like that.
Gotcha. And with that, I kind of want to talk more about the tools because you were talking about PHQ-9. So are there any additional tools that you would also recommend or that you use in those situations with this population?
Do any of the other providers use anything different than the PHQ-9?
Yes, I would say sometimes I use the GDS, which is the geriatric depression scale, and it is more aligned with talking around the concept of depression and not being so direct with it. So it's going to talk to the patient or ask questions about their life enjoyment or about their feelings of helplessness and hopelessness, kind of in an indirect way, but a conversational way. And it helps kind of draw the patient in to share more with you about how they're feeling. The PHQ-9 is absolutely an excellent tool. I use that on all of my patients as well. But sometimes they're already familiar with that and they may clam up. But when they see the geriatric depression scale, they may be a little bit more open just for the line of questioning.
Yeah. Do you use any social determinants of health questionnaires too? I think that's a good way to also pick up on kind of some of these deficiencies that may exist in their social realm and physical realm.
Absolutely. I think finance is going to be a major factor there too. Oftentimes patients won't express what they're dealing with financially, or they feel like this is just kind of par for the course, and it's not necessarily the case. And I know that even when we talk about GeneSight testing in office, there is a conversation about finance, but knowing that there are some cushions there to help along with that, and also just knowing what their social setup is at home. Who do you have to talk to? Who do you have that's able to support you along the way? And what's transportation like for you? These can
Yeah,
all be barriers to treatment. So thank you for bringing that up. I really appreciate it.
Yeah.
That's really good. So speaking about treatment, Dr. Hildy, with the perspective of a clinical pharmacist, could you walk us through what does the process of medication selection look like with this age population?
Yeah, and I think it's changed a lot over the last several years, and especially in a geriatric population. I think for many years you would okay, well, we're going to pick here's first line treatments, here's an SSRI, good luck, we'll see you in 4 to 8 weeks and hope it works. And I think now we have many more tools at our disposal. And then I think that going into treatment with these patients, we need to be checking things like kidney function, and hepatic function as we go into treatment with these. And I think that more and more guidance is coming out on this. And then on top of that, and this is, I think, kind of the whole central focus of this presentation is you may only get 1 or 2 shots with these patients, and you want to get it right as quickly as you can. And so we look at things like the Beers list, and we look at things like GeneSight testing here, where we may be able to kind of eliminate some of the possible reasons why a treatment may not work or it may cause side effects. And so hitting it correctly and hitting it early, I think, is the right way of going about doing it. And I think the Beers list is a great resource. And then on top of that, I think GeneSight is a great resource to ensure that we're getting these patients appropriate treatment.
I love that. Are there any additional tools? We're going to talk about GeneSight more for sure, but we've heard Beers criteria, we've heard rating scales, anything else that we use for this population?
Those are majors. I really love the Beers list, especially when we're talking to geriatric patients. They don't always understand the concept of it, but if you are able to say, hey, this is on a list of things, something that they can refer to on their own, I think that's absolutely helpful for them.
Got it. So speaking of tools, so we've talked about PGX now, and we've kind of walked into that discussion, and we know that elderly patients, they tend to have impaired production of their CYP P450 enzymes. And we know that can affect drug metabolism rates, and it can also exacerbate basically the effects of pharmacogenomic variations that already exist. So Dr. Hildy, could you explain how age might actually affect medication metabolism?
Yeah, 100%. Do we have the slide to share on this one? Perfect. So I think we know that over the course of our life, our renal function goes down, our hepatic function tends to decrease, the blood flow to those organs tends to decrease over the course of our life. That's something that I think most people realize. But I think a lot of people don't take into account the genetic variations. And so this is something looking at poor metabolizers for patients on venlafaxine. by age cohorts. And so they have these patients who are less than 40, 40 to 65, or greater than 65. And they are looking at dose-adjusted serum concentrations of venlafaxine in these poor metabolizer phenotypes. And so patients who are under the age of 40, you see their concentration there at 2.4. Patients greater than 65, you see a much, much higher concentration at 18.8. And that's really showing that these patients who are taking venlafaxine have significantly higher, 8 times higher serum concentration in these elderly poor metabolizers than in poor metabolizers under 40. And that's due to multiple causes. That's definitely multifactorial. These patients may have ongoing liver damage over the course of their life, but also over the course of our life, many of our cytochrome P450 enzymes have decreased expression and decreased function. So it's multifactorial. It's both the liver function, but also the decreased function of those cytochrome P450 enzymes themselves.
I like to tell my older patients that, what is the definition of aging? A lot of it is just thought of as becoming less efficient, right?
Yeah.
So that's how we have to view your liver. Your liver is just less efficient. It doesn't necessarily mean you've got liver disease, but this is a product of aging.
That's a great way to explain it as well. So with that information in mind, we're actually going to have Dr. Brown walk us through a patient case study of a 65+ patient and how she was actually able to use the GeneSight test in combination with the patient's other factors, such as their age, to inform their treatment. So Dr. Brown, I'll let you take it away.
Okay, thank you. Okay, so this was an 80-year-old Caucasian female that I saw in my practice. And when she came to me, she was on a telehealth appointment. The patient was dressed in her pajamas and lying in bed with the computer next to her. She was visibly upset and anxious and worried. So during this appointment, she shared with me that she had several symptoms that were of concern. She was the poster child for depression. Essentially, the patient was having poor focus, constant worry. She had a poor appetite, low motivation, expressing symptoms of anhedonia, and she had recently expressed that she lost her husband within the last year and that she was experiencing some loneliness. She was crying throughout the appointment, and she reported that she had panic attacks on a regular basis, but this was happening upon awakening in the morning. And so her standard routine was to get up in the morning, have a cup of coffee, get back in the bed because things were too much to handle. She also had difficulty shutting her brain off at night. So she was experiencing some ruminations, and during the appointment, you could see her fidgeting throughout. She had her daughter-in-law present as well, who provided some collateral information and expressed that the patient was very pessimistic about life in general and that she was self-isolating. And this was something that was of concern because the patient also expressed that they had some hip pain that had been ongoing for a while, which was also kind of debilitating and creating some problems. But she had a primary care appointment to assist with managing that and an ortho appointment coming up. The patient also lived in a completely different state, but was at her son's home during this appointment. And so she essentially had been uprooted from her normal habitat into her son's home. So there were a lot of limitations here that were also contributing to the fact. The patient had tried multiple medications in the past, which included Remeron, Zoloft, Wellbutrin, and Paxil. And during the time of our appointment, she was taking Zoloft of 150 milligrams a day, and then also Buspirone or Buspar, 15 milligrams a day, and Xanax, and actually it was 0.5 milligrams 3 times a day. And so she was on quite a bit of medication in general, but this patient was also an 80-year-old who had a history of asthma, COPD, and hypertension, as well as the hip pain that I previously mentioned. The patient had a mild family history that included Parkinson's disease, dementia, and anxiety with her mother, and then some other family history that included bipolar disorder. But this patient also was a non-smoker. So just those factors, taking those things into consideration, I wanted to see what we could do to offer a better explanation of finding the right fit for her, since she was already on two anxiety medications and a depressive medication, or 3 if you will include the Zoloft for anxiety as well. So when we talked about some treatment options, just the idea of change was upsetting for her. So I offered her the option of doing some genetic testing. She was open to this, and we talked about some considerations before we even did the testing to determine if these would be the right fit for her. And we considered starting her on some Ringzolti. We considered starting her on Abilify, as well as hydroxyzine or Vistaril. And then the option or the concept of thought came in with the Cymbalta due to the hip pain as well. So we developed a plan to do all of these things, or to see if they were going to be a good fit on the genetic testing. And we discussed potential tapering of the alprazolam. I expressed, due to the Beers list, this was not the appropriate or the best medication for her at this time. And I wanted to optimize her outcomes, because if she was on it 3 times a day, she was still having the panic attacks in the morning. So there had to be something else that we could offer her. And we discussed some grief counseling and some additional CBT. So I did educate her on the fact that if we did taper off of a medication that she had been on for a period of time, which was the benzodiazepine, that we would need to do that carefully to prevent any type of seizure precautions. But when we did the test, it came back and showed us that all of the medications that she had previously been on were all in the significant gene-drug interaction category, which you can see is highlighted in red on the page. And including the medication that she was actually currently on, which was Zoloft. All of these medications were in the significant gene-drug interaction, so that indicates that the patient has a higher likelihood of having side effects or poor outcomes from this medication. But if you'll take a look at the clinical considerations, you'll see here that the serum levels were too high for her and lower doses may be required, and that was for every medication that's highlighted in red. You'll also note that on this same category of drugs, or the same category of the significant gene-drug interaction, each one of these also has a number 6 next to it, indicating that the use of this medication may increase a higher risk of side effects. And then also you will note that there is a number 7 next to the mirtazapine. If the patient was a smoker, this would be relevant to know because it could be impacted by smoking status. However, she was not a smoker. And then you'll also see there is an 8 next to Paxil or paroxetine, indicating that FDA labeling identifies a potential gene-drug interaction for that particular medication. Okay, next slide. So if you take a look here, you'll see under the moderate gene-drug interaction highlighted in yellow, you'll see Xanax or alprazolam, which is what she was currently on, as well as Buspirone or Buspar, the 15 milligrams daily. And you will see they both have a number 1 as well. Serum levels may be too high and lower doses may be required. So while she was on 15 milligrams, a lower dose would have been a better option for her. And while she was on the Xanax 3 times a day, lower doses would be more appropriate for her, also considering her age. And so this doesn't mean that the patient cannot take the drug. It simply means that we need to be a little bit more cautious with the management of it and to offer a more personalized approach, knowing how to apply the clinical considerations. So with knowing this, we had to assess the rest of the report. And we saw that the patient's genotype and phenotypes were highlighted here. She had a normal sensitivity to HTR2A, and that essentially means that there was no concern there, as well as SLC6A4, also no concern there. And the SLC6A4 is going to be more specific to certain SSRIs. She was on Zoloft, so this was pertinent to it, but there was a normal response here. And then HTR2A, that's going to be the response to Paxils. And then ADRA2A, this patient did not have a diagnosis of ADHD, but in the case that she did, we would take that in consideration because there was a moderately reduced response here. And then the HLA genes, there was also a normal response or normal risk for things such as Stevens-Johnson syndrome with certain mood stabilizers. Next slide. Here you will see that the patient was an intermediate metabolizer for CYP3A4, which you're going to see that specific pharmacokinetic gene in about 50% or 75% of medications, but at least about 75% of medications on the GeneSight testing. And it's just going to speak to the metabolism of the drug. There are several components here in relation to how she responds to the drug, but also how she metabolizes. And so that's what we're looking at here. Actually, on the next slide, we're going to talk a little bit more about how these are relevant for actually the last slide. We'll talk about it. But in the GeneSight report, when we came back to look at the results for antidepressants, we looked at the non-smoker pages, and you'll see here under the use as directed category highlighted in green, there was one medication on the list, and that was Prestige or desvenlafaxine. And this is a medication that we ended up putting the patient on after carefully considering all the factors in place and tapering her off of the other medications. We started her on desvenlafaxine for the fact that the patient had depressive symptoms as well as anxiety symptoms, and I believe that this would be a good fit for her. So we started her on this, and she thrived. And I want to show you on the next slide kind of how we discuss those outcomes. So as I mentioned before, the patient was a CYP2D6 poor metabolizer. And as you can see here, there were also some intermediate metabolizing options, which were the others highlighted in orange. This essentially led to the reduced metabolism, which also increased the risk for side effects in several of the medications that she was on, including mirtazapine, sertraline, paroxetine, alprazolam, Buspar, and propion. So with that being said, again, the CYP3A4 is involved in the metabolism of about 75% of those, and CYP2D6 is involved in a metabolism of about 61% of the medications on the GeneSight report, and about 25% of those medications in general. Well, when we started the patient on this particular medication, and again, I mentioned we took all those factors into consideration to taper her down, we saw a PHQ-9 score that reduced from 11 to 6 following the medication adjustments. And so this was amazing. At the appointment that followed up after initiating this medication, the patient showed up fully dressed, sitting in a recliner. She had makeup on. She was smiling. She was doing well. And this was something that I was not prepared to see. I expected some progress, but not as much progress as that I saw during the follow-up appointment. And so she expressed to me that her mood was better. Her energy was better. She was focusing. She had not been having crying spells, and the worrying had not been as much. She did express that there was some worry because she had an upcoming hip surgery, but that worry was specifically related to that concern and not the way that she had expressed it before. So we were able to take the patient down from 3 medications to 1 medication, reducing the polypharmacy. And this patient is still thriving. I saw her about a week ago, but prior to seeing her a week ago, she expressed that she had gotten rid of all of the anhedonia, that she had done so well that she looked up an enrichment course on a local community college site, and that she had started going to that just for socializing, just for being present. And she had also started drawing again, which was something that she had previously enjoyed doing. I could not tell you that I expected this outcome. So to see her and to hear her say this, she told me it was the best that she had felt in years. And again, this patient was at visiting her son, and she was supposed to go back to her home state. So she declined to change providers. So she is going to fly in to visit her son on a regular basis so that we can continue care. But that was all because of GeneSight.
Wow, I love that. Oh, that's such a great patient case. Thank you so much for sharing that. I'm going to go ahead and stop sharing these slides. So I'm sure our audience is curious, what does a test like this cost for this patient population? So Dr. Brown, could you share how do you discuss the cost with this patient population when you offer GeneSight?
Absolutely. So when I'm discussing this with any patient population, I always want to start with transparency, and I express to them that cost is dictated based upon your income, but also your zip code. But for patients who are on Medicare or Medicaid, this is $0 for them. So there's there's no question. If it's free to the patient, when we can optimize their outcomes or at least assess to see if there are any concerns that we can avoid, then let's do that. But yes, $0 for patients on Medicaid or Medicare. And for patients who are not on Medicaid and Medicare, out-of-pocket maximum cost is $330. Doesn't matter if you're Beyonce or Taylor Swift or whoever. So $330 out of pocket, but there are financial programs available to you. And I want patients to know that they can give the phone number on the back of the GeneSight pamphlet a call, and they will assess and run the information for you to see where you fall. And there's also availability on the website for GeneSight to type it in and get an estimation.
Perfect. Thank you so much for that. And if anyone does have additional questions about cost or for specific patient populations, again, you can put that in the QA and we can respond to that question. But I do want to ask everyone, now that we've gone through that example, when do you guys utilize the GeneSight test in the 65 population? And Dr. Wyrick, we'll start with you.
I think anytime I'm considering any pharmacotherapy, the conversation about GeneSight starts right away. I don't have a standard of you got to try and fail a certain number of medications. I would say most cases when it is actually utilized, we have at least tried and failed one, but it is appropriate to consider GeneSight at any step of the process if you are truly thinking about a pharmacotherapy. And as we've seen on all these examples, these green, yellow, and red categories are just a lot brighter, is how I think about it with our, 65 plus population, because their enzymes are not as efficient and because these other factors may be a lot more exacerbated and put them at higher risk for side effects. So Casey even alluded to it earlier too, you may only get a couple opportunities to treat this patient. And, part of this, especially in the primary care setting, is relationship building and trust. And I want to make sure that I am instilling in them, I'm trying to get information about them that they cannot tell me. And so let's get this test, allow us to sift out so many extra medications, since we know that there's a slew to look through with all these guidelines of first step, second step, or first line, second line. And so I think patients really buy into that idea and understand that you have their best interest in mind in wanting to do a test like this. And so when the cost is zero for a Medicare patient, it's not much of a selling point. It's much more of an accessible tool. Why not utilize it?
Awesome. How about you, Casey?
I think on top of that, I think that GeneSight has several kind of nicely well validated studies in regards to cost and potential cost reduction for these patients in terms of total healthcare expenditures and med spend. I think in our case study earlier, we saw that reduction in polypharmacy, and so that's even if this patient did have to pay a certain copay, or even if they had to pay the maximum of the $330 over the course of the year, that they're going to make that back just in drug spend realistically. And so being able to get those patients on a medication early that works, it saves them from unnecessary copays on these medications. And also just for their overall well-being, they're able to start something that has a higher probability of working right off the bat. And I think the same thing in the case study that we saw earlier. This patient was on a high-risk medication, a benzodiazepine. They're wanting to go have hip surgery. If they were continued on the benzodiazepine, had hip surgery, and were written opiates, we were looking at a potential for a fall. And so I think that we're able to kind of help with some of these potential medication interactions on top of these genetic interactions by doing this early on. And so I'll reach for it as quickly as I can. I have these conversations early with patients. Typically, patients are referred over to me after they've already trialed and failed something kind of initially. And if we're looking at something branded, or if we're looking at adding an adjunct that may be an atypical antipsychotic or something like that, I think it's very important that we screen for these potential risk factors. And so I think that it's in your best interest and your patient's best interest to do these types of testing early on. And these are once in lifetime testing. These shouldn't change really over the course of your life. And so $330, I feel like even if you are paying the larger amount is not very much for something that tends to be once in a lifetime versus I have everybody asking me for Ozempic and it's $1,200 a month and you're on it forever. And so it's a vastly different ballgame with these genetic tests that are typically one and done.
That's a really good point. How about you, Dr. Brown?
I would totally agree. I start the conversation about GeneSight testing from the initial appointment. I solely want them to know that it exists because I cannot predict when we will come to that conversation or have that turning point. But also, when a patient has tried more than one medication, sometimes the window is very small. And when you have a patient who is a geriatric patient, the time behind them is more than the time in front of them. And so offering them a sense of quality of life and closing that gap as quickly as you can is a big deal. The time is precious in general, but also keeping in mind what Dr. Hildy said in reference to branded versus non-branded. Sometimes you're going to be looking at fighting the insurance company to achieve the medication management that you deem that is best for this patient. But now you have an objective tool to submit for your PA. You are able to support why this decision is better versus whatever other decisions or options that you've considered. And just like this patient, there were multiple other factors that we considered and also other medication regimens that we considered, but none of those were optimal when we checked out the genetic testing. So even though we came up with a plan, they weren't optimal options. So that was just using the treatment as usual method. But now we have something that we can offer our patients, which is clarity and objectivity, and hopefully provide them with better quality of life all the way around.
I love that. It really does show how it's just one other piece of the puzzle when we're looking at the total patient picture. So before we wrap up, I would love to hear from each of you one last time. If you guys could just briefly highlight how you've seen the GeneSight test lead to better treatment outcomes for your patients. And Dr. Brown, we'll start with you this time.
Sure. I believe that the GeneSight test offers so much information. And again, it's what the patient can't tell you. No one can look at you and determine if there is a clinical factor that's preventing you from having the outcomes that your clinicians desire you to have. And everyone doesn't respond the same to every medication. So I have seen GeneSight offer insight to what the missing piece of the puzzle is, and offering remission to several of my patients, improvement in quality of life, but also hope because they have believed for such a period of time that nothing will work for them, but understanding the why gives them a sense of peace, if you will.
I love that. Peace and hope. Those are both two great things to have. How about you, Dr. Hildey?
I think that this is a tool in the toolbox, and I think that utilizing this tool, it's not necessarily going to tell you just because it's green that this medication is going to work perfectly for this patient, but it is going to allow you to rule out medications that likely might cause that patient harm. And I think that that's why we all get into medicine in the first place, is we want to help these patients, and these patients are suffering. And if we're able to help that patient sooner, which GeneSight has shown time and time again in their trials, that they offer an improvement in quality of life. They offer a decrease in HAM-D scoring, and they offer an improvement in remission. And so these are all things that we want to get done sooner. And this allows us to prevent patient suffering sooner. And I think that's the most important thing for these patients is we're wanting to try them on these medications, and we're wanting them to not have to jump through too many hoops. And we're not wanting to have to jump through too many hoops. And so it's a nice tool in the toolbox to be able to offer our patients. And for many of them, it's fully covered. For many of them, it's the cost is low, and these are once in a lifetime tests.
Yeah, great answer. Dr. Weber?
Yeah, clinically over and over again, I've seen the response with just success with remission, reducing that polypharmacy, which is crucial. And ultimately it comes back to building relationship with me too. You know, after we utilize a test like this, they see what, my hope was for it and what we got out of it. Again, helps strengthen that relationship. But I'd say the most beneficial thing I see over and over again too is the reduction in side effects. I've got case after case where we've actually reduced SSRIs because they're, SLC heterozygous and maybe on too high of a dose of SSRI, even though SSRI is still right for them. We just reduced that dose of SSRI. And next thing you know, all these years of GI related symptoms that they were having are next to nothing. And lo and behold, we probably scoped them. We've probably CT scanned them. We've done everything to rule out GI related issues, found nothing. And lo and behold, we've reduced that SSRI. GI wise, they're doing much better, and their anxiety and depression are still well controlled. So story after story just speaks for itself. And it is It's got to be a tool that's in your tool belt, and you don't have to be a pharmacogenetic specialist to be able to get something out of GeneSight. Let it speak for itself.
That's a really good point. That's a good way to end it. Let it speak for itself. Well, thank you guys so much for your time this evening. And to our audience who is listening in, I just wanted to say that we are replying to Q&A still. So if you have questions, please get them in. We have our team is replying to the questions privately. So please look for your response. But that's all we have for you this evening. And this webinar is going to be available as a recording on our YouTube channel as quickly as possible. Thank you particularly to our wonderful clinicians, our panelists, who just took some amazing time to share your knowledge about GeneSight testing. And we just thank you everyone for joining us this evening. So have a good night.
Thank you for having us.